So, Assalamualaikum everyone. I'm Dr. Ammar Pirzada, currently working as a Year 2 fellow in the section of peripheral vascular surgery at the Khan University Hospital. In our today's session of Giant Club, we'll be discussing this very interesting topic based on shared decision making. This is a very recently published article. It was published last month only in the European Journal of Vascular and Endovascular Surgery, and talks about the predictors of the level of shared decision making in vascular surgery. It is basically a cross sectional study. So before we contemplate on this article and I go into the details, the first question that came into my mind, obviously, after reading this was what exactly is shared decision making? And I think a few participants would be exactly wondering the same here. So this is a process to ensure that a decision is made, a decision is reached, and it is not enforced upon the patient by his primary physician. This is basically the soul of this whole idea of shared decision making, that there has to be consensual decision making. So the next question automatically that comes to our mind is, then who makes a decision if it is not for the primary physician? Because the age old way of dealing with all the pathologies has been that the doctor knows the best, and the patients are supposed to follow doctor's instruction. But with the passage of time, things have changed, and now a more collaborated idea is in vogue. So there has to be an effort between the physician and the patient himself, which is based on the recent evidence. So there has to be a consensual decision and not just one-way traffic where the physician decides and the patient follows. So the basic objective was that even though the patients with vascular disease, they often face multiple treatment options with different risks and benefits, the application of shared decision making remains low. The study aimed to reveal predictors of the extent to which the SGM process occurs in the field of vascular surgery. The basic rationale was that 3 or 4 patients with peripheral arterial disease or abdominal aortic aneurysms have inadequate health literacy. This makes informed decision making, understanding the pros and cons of each treatment option, of which some can be potentially irreversible at times, all the more important. So SEM also brings in beneficial effects on patient satisfaction, treatment adherence, better compliance, and disease-specific knowledge without raising anxiety levels. Currently, shared decision making as an idea exists, but practical implementation is not very common, not just internationally. And if you talk about our part of the world, I personally think it is not very well known. 3 factors that literature has shown to have achieved high objectivity in terms of gaining patient perceived satisfactory SGM levels are patient education. The better the education level is, the better is the shared decision making levels, employment status, and importantly, consultation duration, the time duration for which the primary attending talks to the patient. Relating patient and consultation characteristics to objective shared decision making scores might yield more reliable predictors of the actually achieved level of shared decision making. Therefore, the main objective of this study was to reveal significant independent predictors of the level of shared decision making in the field of vascular surgery. This basically was a cross-sectional cohort study. So to begin with, it is a sub-study of the landmark Ovidius trial, which was a multi-center randomized stepwise trial examining the effect of decision-making support tools on the level of shared decision-making. The association between the objectively measured SDM scores and the following independent variables as derived from the literature were investigated. This included education level of the patient, what is the disease process, the length of consultation, the number of consultations that were required, and patient employment status. There were other few variables that were also added later on. This included age and gender of the patient, the number of participants in the consultation that were present, the profession of the physician, whether he was the primary surgeon or a trained or specialist nurse or a trainee, and the sex of the clinician. Coming to participants. Adult patients eligible for more than one treatment option, including the option of not to treat as yet, were included consecutively. The patients were informed a week prior to their induction, and obviously consent was taken. Clinicians were also informed about the study, and they were asked to audio record the consultations with eligible patients in which a decision was to be made. 3 different vascular disease processes were included. This included AAA, varicose veins, and intermittent claudication patients, predominantly those with Fontaine class 2B with some moderate claudication. Patients are included in AAA group if diagnosed with an asymptomatic AAA with a diameter of 5 centimeter or more in women and 5.5 centimeter or more in men. Similarly, for intermittent claudications who had undergone supervised exercise training according to the current guideline but with unsatisfactory effect, they were also included. Patients with varicose veins for whom minimally invasive treatment was considered, they were also included in the study. Before the patients formally joined these consultation sessions, they were asked to complete a questionnaire that was based on demographics, which included the age, gender, ethnicity, education level, low, medium, high. It was classified on the basis of their education. So primary education was labeled as low, secondary education as medium, and higher education or specialist education was labeled as high level of education. Similarly, whether they were employed or unemployed and what was their marital status. This is a screenshot of the questionnaire that the patients were asked to fill in. This basically, grossly speaking, included the demographics and the disease process, their lifestyle, their education, their employment status, and their ethnicity. Coming to clinician characteristics. So, researchers registered in the profession as they were broken down into three groups, whether they were in training like fellows or residents, or the interview was being done by nurse practitioner or a specialist, and importantly, if it was being done by the main surgeon himself. The sex of the clinicians was also recorded. Importantly, none of the clinicians had any previous training in shared decision making. Coming to consultation characteristics. So all the consultations were audio recorded. The observers registered the length of the consultation in minutes, the number of consultations that needed to reach a decision, whether it was done in one setting or it required more than one sessions, and the number of participants, including the clinician in the consultation room. So the next question after all this understanding was, is there any objectivity to measuring the concept of shared decision making level? Is there any checklist how to go about the objective criterion? So again, the answer lies in this option instrument that was used by the obedience trial. So basically, they used to score the extent to which the clinician involves the patient in the decision-making process during consultations. This slide is the crux of this whole article. So there are five variables on the basis of which every consultation session was evaluated. So as part of this evaluation, item one included the general discussion, which was basically generated by the healthcare provider or the surgeon, where whether he or she is talking to the patient and giving them the other alternate options other than the main option that is the go-to option in the mind of the surgeon. So whether alternate options are being discussed or not. Then the second variable is that whether the surgeon is conducive enough and agreeable to the fact that the patient can deliberate and think, and he is open to discussion in terms of patient's ideas or patient solution to this problem, which may not sound very logical to the surgeon, but he or she should at least be open to this discussion. This is known as team talk. Then item three is option talk, where the options, the practical options are further discussed, and it is a responsibility of the primary clinician to give detailed information about all the alternate options that are available to the patient. And lastly, there are two components which basically are related to the decision that is made on the basis of patient's preference. In item 4, it is imperative and it is the onus is on the physician to elicit the fact that the patient should be open enough to express his own preferences. Few patients may not like prolonged hospital stay. Few patients would like to go for everything to achieve treatment. So there can be different preferences. Few may be sporty individuals. Few individuals may be more worried about their cosmetic results. If particularly if we talk about varicose vein surgery, so they should be the clinician should be open enough to elicit their preferences, and it shouldn't be one-way traffic. And lastly, once the clinician has heard their preferences, what exactly is he doing to integrate those preferences in the final decision that is to be made, obviously in consultation with the clinician, but the preferences of the patient should be an important part of the decision making process. So these are the five variables, and each consultation session was basically judged, and there was a score given for each of these five variables. So each item is given a score between 0 and 4. So 0 obviously means that the clinician did not make any effort, and 4 means that he was going all out for it. The maximum total score is of 20. Audio tapes were analyzed twice by two of the three evaluators independently. Before analyzing these tapes individually, 10 audio tapes were analyzed by more than one evaluator to test inter-rater reliability. If items were scored differently, scores were discussed until consensus was achieved. Coming to the data analysis part of this article. Descriptive statistics were applied for patient and consultation characteristics and shared decision-making scores. Patients and consultation characteristics were presented as mean standard deviation or median when appropriate for continuous variables, and for categorical ones, they were presented as percentages. The total option 5 score was converted from a 0 to 20 point scale with the previous flowchart. It was converted from a point scale system to a percentage scale and presented in the form of mean standard deviation. Univariate and multivariate linear regression analysis were used to find significant independent predictors of the level of shared decision making as assessed using the option 5 score. The first univariable linear regression analysis was performed to check for correlations between the patient or consultation characteristics and the observed score. So what exactly is the relationship between two? And on the basis of that, variables were selected for multivariable linear regression analysis if the p-value was less than 0.001. That is, they were coming out to be significant on univariate linear regression analysis. A value of 0.05, less than 0.05, was considered statistically significant. They used SPSS version 6 for all these statistical analysis. This was about the methodology and objective parts of the presentation. Now coming to the results. So the observers analyzed approximately 356 audio tapes from 342 sets of patients from the OVDS cohort. The mean total score they observed was 33.8%. Compared with patients with AAA and intermittent claudication, which were mostly older males, patients with varicose veins were more often younger women. The mean patient age was 64 years. Majority of them were men, about 59% of them. The median duration of the consultations was 14 minutes and 31 seconds. The range was quite wide, ranging from 3 minutes to 58 minutes and 52 seconds. Because the duration was not normally distributed, they created 4 groups. Group 1 was less than 10 minutes, then 10 to 20 minutes, 20 to 30 minutes, and more than 30 minutes. In total, 42 clinicians, 23 men and 19 women participated in this study. Majority of them were vascular surgeons, about 69%, more than two-thirds. 19% were residents in training, and 12% were nurse practitioners and nurse specialists. 47% of the patients were accompanied by their partner or family member, and in 54% of the consultations, SDM tools were used to improve the SDM process. The lowest scoring item was item 2, which basically talks about possibly the mindset where the physician has to agree to deliberation, where the physician has to be open to patients' solutions to the problem. So this was the lowest scoring item among the 5 criteria that they selected to evaluate SDM levels. And the highest scoring one was item 3, which basically talks about providing details of all the alternate options that the patient has. So this is an interesting choice, that even though the physicians were giving alternate options and they were giving all the detailed information related to those alternate options, they were not really very open to deliberation in terms of inviting the patients to come up with solutions. So this was an important finding. Few variables were included in the multivariable analysis based on significant p-value in the univariate analysis. This included the age, sex, diagnosis, education, and employment status of the patient, the sex and profession of the clinician, whether it is a primary surgeon who is performing the counseling or the trainee or the nurse, the duration of the consultation, the number of participants in the consultation, and the number of consultations prior to decision. On the basis of multivariate regression analysis, diagnosis, clinical profession, and duration of consultations, these were the 3 important factors that were significant enough in explaining the variation in SDM levels. Consultations with patients with intermittent claudication and varicose veins resulted in a 9.9 and 12.7 respectively of 100-point lower SDM score as compared with consultations with AAA patients. So basically, AAA patients performed well in terms of SGM score as compared to the other two disease processes that they included, intermittent claudication and varicose vein. Similarly, surgeons performed better in terms of their SDM scores as compared to nurse practitioners or residents with comparatively lower scores of 4.2 and 8.6 point lower than the main surgeon scores. Importantly, consultations that took more than 30 minutes led to a higher score, 5.8 point higher score compared with consultations that lasted for less than 10 minutes. This basically is the table that they created, and they showed the certain impact of certain factors on how well the SGM score looked. So if we look at this carefully, we see that intermittent claudication and varicose vein could not do really well against AAA. So if the counseling of AAA, to simplify this, performed, the SGM score was better, and the counseling was done better for AAA patients as compared to the other two. And this stood up both in univariate analysis and in multivariate analysis as well. Similarly, surgeons outperformed trainees and nurse specialists in their counseling scores. And as far as the duration is concerned, if it lasted for more than 30 minutes, the score were higher as compared to lesser duration, particularly if it is less than 10 minutes. This chart basically compares the three disease processes and the five option items that I mentioned previously, and we talked about them. And this basically shows that, again, AAA is a disease process where the highest SGM score has been achieved as compared to intermittent claudication and varicose veins of about 43.2 with 30.6 variability. And in AAA as well, and just like AAA in the rest of the disease process as well, it is the item 3 where the authors talk about giving complete information for every alternate option. This basically outperforms the other 4 variables. So interestingly, the surgeons are open to discussion, but in terms of providing all the information that is available in terms of alternate options, but not really they are going for the inclusivity of preferences of the patient, or the deliberation part of the process where the patients are encouraged to be a part of decision making. So the options are discussed, the pros and cons are discussed in detail, and that is the best scoring shot for SGM tools for surgeons or sorry, or physicians. But the patient participation part is lacking. Quickly moving towards the discussion. So, in this study, the associations between patient, clinician, and consultation characteristics and the level of shared decision making were investigated in vascular surgical consultations as measured by using the option 5 instrument. The mean scores found in this study was about 33.8%, which was slightly better than in the previous studies using the same instrument. But even then, there's a significant room for improvement. A similar study was published in 2016, and the score for that study was about 31%. So yeah, there is some improvement, even though it may not sound very huge in terms of percentages, but there is improvement. To further improve the implementation of SGM, vascular surgeons should first be aware of the importance of this whole phenomenon and how to integrate in this in decision making with the patients. Decision making support tools such as patient decision aids, choice cards, or option grids may help in this process. In addition, this study revealed several predictors for a better performance in terms of SGM tool. First, the consultations with patients with AAA showed higher SGM levels than those with intermittent claudication and varicose veins. An explanation could be because of the fact that patients with AAA more often face equally effective treatment options according to current guidelines. And on the other hand, for intermittent claudication and varicose veins, the guidelines nudge towards one of the options. As a consequence, clinicians are less inclined to initiate the weighing of the pros and cons of all options and to elicit the patient's preference. In addition, AAA consultations were more often conducted by vascular surgeons than intermittent claudication and varicose vein consultations, which also explains the higher SGM scores. And most important factor to this would be the experience factor, because the main surgeons, they have seen this all through, so their counseling would obviously be better than the trainees or nurse specialists. Even though the nurse practitioners showed less SGM behavior than surgeons, studies show the potential of the meaningful and supportive roles that nurses could play in the process of shared decision making. Nevertheless, the overall option 5 scores, including among surgeons, show room for improvement. Third important factor is the duration of consultations. So, if it goes for more than 30 minutes, the results are better. As often stated, strategies for improving SGM should address the duration of consultations, as a standard duration for outpatient consultations in many European countries is about 10 minutes, which may not be adequate enough. However, the use of patient decision aids may better inform and prepare patients before their visit to the surgeon, which would reduce the time needed to explain treatment options and the possible undesired effects during the consultation. This decision aid can be videographic. This can be a software with an interactive software based phenomenon, or on the basis of card system where the patients can choose cards based on their preferences. With this, I would end the discussion part. Lastly, I would be sharing, the authors shared a link, the tool basically which they use for 5 major disease processes for vascular surgery. It's a interactive videographic tool, and I would be playing the video of this for the diagnosis of aortic aneurysm. They have shared the link in the article. So if we click on the link, this window opens up. So I have just selected only aortic aneurysm part of this, and let's go through this video quickly. So once the patient selects his disease process, I hope everyone can see the video. So this starts basically with the description of the abdominal aorta, so that the patient gets a know-how of what exactly is going on in his body. The basic anatomy of aorta in terms of its sizes and what is the definition of AAA, what exactly is going on in terms of increase in size and aneurysmal dilatation of the aorta. The basic definition of this, the risk of rupture that is associated with aortic aneurysm. Then each individual can measure his own risk based on the size of the aneurysm on imaging. Then they tell what exactly is the aim and why do you need treatment, and how do you decide which patient needs treatment. They talk about size in women and in men, what is the cutoff size, and how the decision making process will go. Three different options in terms of surveillance, endovascular, and open surgery are discussed. The details of active surveillance. Now, coming to the endovascular part, they have simplified this with the name of surgery via groin. So now they're explaining that how the access is taken for EVAR, the wire goes across the aneurysmal sac, and then a stent is passed over it. First, they have shown the main body. So each step of the procedure is being explained in a simplified way, so that the patient can make a decision consciously. Now, coming to the open surgical part of this, now they're showing that they will go in via laparotomy approach. Obviously, the incision would be bigger, the clamps would be applied, the risk of suprarenal clamping is also explained, the process of opening the aneurysm, placing the graft, suturing it up. So all these processes, they may look very simplified to people who are associated with vascular surgery, but for a layman, this is actually interesting and builds their interest to think about their own selves and to make conscious decisions. The process is being explained that now the aneurysmal sac is closed, and finally the abdomen would be closed as well. Now, the interesting part to this presentation would be that all the three approaches, they will now explain the risks that are associated with this. Few risk factors are common with both the open and endovascular approach, and few are related to one particular approach. So now they're explaining the benefit for surveillance versus surgery by groin, that is EVAR versus open surgery. Everything is based on the level of understanding of the layman. Now they are telling the risk that is associated with open approach or endovascular one. These are the few commonly asked questions, and based on this, they have included this table. So these questions and their answer for one particular approach is given here. That how long would be the hospital stay, where would anesthesia be required or not, recovery time period, follow-ups, and importantly, whether this will cure the disease or not. Then it's a questionnaire to assess whether the patient has understood this whole process or not, and the patient is asked to fill this. Now, the patient is asked, just like a liquid skill, to tell whether they are very much satisfied or not, whether they are kind of in between. Do they like this idea of general anesthesia? Do they like regular follow-ups in terms of ultrasound and CT scans? So it is their input that matters a lot. So it is to involve them in their decision making. And at that particular moment, what is their preference and how sure they are in terms of their decision making at this point. So this is very interactive and this keeps them involved. And finally, the answers are submitted and they will eventually summarize the whole process for the patient. That was about the interactive tools that are available, um, freely available on internet. So thank you very much. Thank you everyone for the patient listening. And I'm really sorry for this technical glitch in terms of slideshow. Thank you once again.
Yeah, thank you, Ammar. This is very nice presentation, and not to worry, these are common problem with online sessions, and you have nicely described this paper. I have selected this paper because this is a common process we do in our daily life, that is consulting the patient, helping in their decision making, and helping in the choice of the procedure which are there. But the shared decision making is a novel concept which has been adopted by many specialties. It helps the patients uh, in selecting their choice of treatment. Unfortunately, the concept is not much practiced, and that you have readily seen, not to talk about our own country, but it is even in the West. This process is not well adopted, and that is well seen that patients who are going for varicose veins treatment and for intermittent claudications did not have more shared decision making as compared to abdominal aortic aneurysm. And when it comes to the junior doctors, the shared decision making is not done. So one is the emphasis, and then we can actually develop ourselves or train ourselves how we can involve our patient in the shared decision making and help it up. You have rightly pointed the very useful links which this paper have, which we can use for our patient for carotid disease, for varicose vein disease, for abdominal aortic aneurysm disease. And that is quite useful information for a lay person and the common question which are there. So I will like the comments and the questions of any participants, which how they think what are the hindrances or the barriers in the shared decision making which they find in their practice. Dr. Freed has raised the hand. Dr. Freed.
Thank you, Dr. Jai, and thank you, Ammar, for such an excellent presentation. I think this is a very important topic. I'll just take 2 minutes. The other thing is, Ammar, you talked about there was some education level mentioned somewhere in the grid. So my main
Yes, sir.
concern, my main concern is considering our local setup and the education level of our patients, where you often see the attendants asking you not to tell the parents, Baba, Ami, whatever, कि उनका ये ऑपरेशन होना है, उनको कैंसर है, दे आर फियर्ड ऑफ दैट एंड देन दे फियर कि वो डिप्रेशन में चले जाएंगे. So my worry is that in that situation, although we do inform patients, but in some muffled way, I think many a times. So what did they talk about? So did they compare the education level of the patient and its impact on the outcomes of this? Do you have any information about that?
So, sir, the parent article, the Obedience trial, that basically initiated this process. So it talks about the fact that so the understanding of the West is different from us. In our setup, it is a family basically who's calling the shots, but outside they are very clear with this parent article that it is the patient's right to decide what to do with his limb or life. So the concept of not telling is not much explored in these articles because it's a concept alien to them. It is something very common to us, but for them it is the patient who decides, unless the patient is in such condition that he or she cannot make his own decisions because of sanity issues. So that is why they do not further talk about this much in the obedience trial as well. And
No, I
based on
understand that. I
education
mean,
alone.
yeah, education, I'm more interested. Yes,
So
please.
from so sir, based on education alone, statistically significant results were not obtained. The three factors that they identified in terms of significant results were duration, surgeon himself counseling, and in terms of disease, AAA doing better as compared to the other two. Yes, patients' education helped in terms of producing results. They were not very statistically significant results. So the three predictors that they have identified based on this study are does not include the educational part of the patients.
Okay, thank you. So I think I will just close and would love to hear from other colleagues. Like in our setup, even you encounter a well-educated family, they mostly rely on you, asking you, Doctor Saab, आपके ख्याल में क्या करना चाहिए? We are at your hands and such things in the clinic. So I think we do explain everything, the pros and cons, what are the alternate options. But at the end of it, in our society, the onus lies on us. So how would you guys deal with that? I would love to hear from the respective colleagues. Thank you.
Farid, you have raised two very important points. One is the educational level. Secondly, patients don't want to make decision, and what is the strategy in shared decision making. So we have to understand there are studies which have shown that shared decision making do help in patients who have low educational status, or who are not have formal education. Shared decision making do help in the treatment option. Secondly, we have to understand sometimes there are patients who do not want to make the decision of their treatment themselves. It is fair to them, but it is nice to give them the options, and then they rely on the physician to make the decision. But it is patient's right, and this is the whole idea that they must be knowing all the options available, all the pros and cons, and if they end, it is also okay if they do not make their own decision and rely on you. This is just like a teamwork which is there. And I see Dr. Nadeem hand raised, and then we can actually build the discussion on our that. Dr. Nadeem.
Well, thank you, Ammar, for this nice presentation. I think I will take this presentation on two fronts. One is the concept of shared decision making, that how actually we can translate this concept to our society, our community, our practice. And the second is about this article. So I will talk about the second thing first, that in this article, we know that the physician or the nurse practitioner or resident knew that he is being audio taped, which ultimately can affect the overall discussion process. Because we know, okay, when someone is, we know, okay, that there is a camera, we stop at the red light, but sometimes we do not do that. So if we know that we are being audio taped and this is gonna be used for any research purposes, the interaction level and overall approach changes. So this article may not really reflect the actual status. So the numbers may be little bit more down. This is one thing which we have to understand. Number second thing is the concept lies basically has a ethical foundation, and we all know that. And I'm sure most of us and almost all of us do these things. My question to the forum is that how can we use this concept in our society? Because people many of the time say, okay, by Dr. Saab, you are the only one who was there, who just tell us what to do and we will do the same thing. And we despite offering them ended up making a decision, which sometimes do happen. So ये हम किस तरह से हम यहाँ पे कॉन्सेप्ट को पहले तो हमें देखना चाहिए कि हाउ मच good we are in shared decision making. Then how can we apply these, especially amputation? I don't know, which is an important aspect. उसमें किस तरह हम इसको कर सकते हैं, and that's how I think from our perspective we should go about it. But it is, I agree, it is important to discuss about it and measure the important factors which may hinder the process of shared decision making in our part of the country. Thank you.
Thank you, Nadeem. That these are very good points which are raised. Very good point is that the study has some limitation. One of the limitation is that maybe the objective criteria gained by the shared decision making in the article is more because they know they are being audio taped. And in real clinical practice, the situation is totally different. And same is true, which we see in our busy clinics. Actually, this is a concept, and the barriers which I find is the time limit, because it takes a lot of time to explain those patients, to tell every pros and cons, and then let them, the most important is involve the patient in decision making. Let them talk the patient and then inform the patient. And this is one of the hindrance. And we see in our clinics are so busy that we do not have the time, and same is true here in the West. And then sometimes we have not the whole information, because this here decision making is based on the evidence base, and sometimes the information is not available to us, and that is one of them. And third is the most important is the attitude of the clinicians, because we still think that our whatever we are thinking is the best for the patient, and it is most of the time. But how the patient are going to adjust in their lifestyle is not known. One very beautiful example is given by of a person who have a colorectal carcinoma, and one of the main option which was offered to that patient was and he was having very good lifestyle, was the major surgery. And the patient was never involved in his decision making. Patient has a family to whom he wants to visit. Patient has a good lifestyle. Patient was not asked that, was never told that after the surgery what are the complication and how it is going to affect that lifestyle. Patient was having also some respiratory problem. Patient underwent surgery, and then patient unfortunately developed pneumonia. Patient was readmitted in the hospital. During that hospital, patient got sepsis. He went into dialysis, and he had to visit the hospital to every week for the dialysis 3 times. And he was totally away from his lifestyle, which he was enjoying. And then the complication raised. And if we see his whole picture after 6 months, whatever his life is left, was not as good, as quality of life was not as good as before that decision. If the patient has been involved and told, then it would have been totally different. So this is actually involving and listening to the patient and listening it quite patiently, and then actually explaining all options, and then patient coming up how that is going to affect it up, and then making a combined decision, a collective decision, a collaborative decision that may be happening. I feel that we in our daily practice lack it up, and sometimes we do not tell the patients the whole risks and benefits, and that I see, and that I see there. The main reason may be the time constraint, and sometimes we think that this time is wasted, but in my opinion, this time is well spent, because because patient become more compliant, patient become more satisfied, and because patient get the ownership of his own life and his own decision making. That I see. This shared decision are very objective decision making, does make improve the quality of the patients. And one interesting part is the involvement, means there's a 3 points in the decision making. It is just like the concept is that in a room there is no one expert, there are 2 experts. One is the expert of the disease and the multiple options available, and one expert is the patient who knows the best about the patient preferences and the lifestyle, and these 2 talk together of different options which are there, and then actually compare them up, and then come with a combined decision. That I find, and maybe with spending some time with the patient, we can also develop this strategy, and that can help most of the patient. That I see. If there's any other questions or comments that are most likely, most welcome. We have Fizan, Nihal, Dr. Adil, Dr. Abdul Basit, and Muhammad Nasir with us. Yeah, we cannot hear Abdul Basit. So if there's no comments, we can close. Gigi.
Thank you so much, sir. It was a very nice talk. Alhamdulillah. Many of our questions are already answered. Thank you so much, sir.
Okay, so we can stop this session. Thank you for participation. Thank you, Ammar, for presenting the article. Thank you.
My pleasure, sir. Thank you everyone for joining in.